It is time now. We're gonna officially start this webinar. Let me introduce myself first. I'm Fiona, International Business Manager from Minimax Medical and F-Care Systems. We are a professional manufacturer of radiofrequency ablation system for different applications, including in interventional oncology, endovascular, as well as proctology. And we have experience of more than decades. And here in this webinar, we are very delighted to have invited Dr. Vivaldi from Germany to share his experience and also tips in how to do ablation for hemorrhoid using our product. And he started using our Rafaelo system since 2015, and he has finished around 1,400 cases, and he has plenty of experience sharing his expertise on Rafaelo procedure across Europe, Middle East, and also in Russia. And in this webinar, we have doctors joining from countries including Singapore, Vietnam, Indonesia, as well as Malaysia. And then this webinar will have two parts mainly. Firstly, Dr. Vivaldi will share his experience and tips, and then the question and answer part. So Dr. Vivaldi, I will give the rest of the time to you.
So thank you very much. Welcome, everybody. It's a pleasure for me to be today here. Sorry, and explain a bit or tell you a bit about the Rafaelo procedure, what we are used to do with the hemorrhoids. And for me, it's a very good pleasure and very easy that Michael Pierre from F-Care will help me with the slides and the presentation, which is very comfortable. So we can try to go and start. Right now, yeah.
Yeah, you can see. Yeah,
I can. Yeah, exactly. This is what I wanted. That is big. Yeah. Well, we are talking about. It's not the first slide, no, but the third doesn't matter. We're talking about the Rafaelo. Thank you. And the Rafaelo. The name is interesting because, as you might know, we have in Europe and all over the world now from Ferrero exists this Praline Rafaelo, but it's not the same. We write it a little bit different. The company was just here smart and took from the long-term radio frequency ablation of hemorrhoids in local anesthesia. They just took some letters and created this Rafaelo, which keeps very nice in mind. And yeah, so we can go on. Now I explain that. Next. Here is now the full word, full term. And we are talking now in the next slide about what you need and how the thermocoagulation works, which is quite different to usual thermal sources because we have here radio frequency ablation, which is electromagnetic waves. They get emissioned by a high frequency of 4 megahertz. And because of this, we have 4 phases of the thermocoagulation. It starts in the tissue with the ionic agitation, then the dehydration of the tissue, a denaturation of the proteins, and in the end, as longer you keep the energy on, for sure, you have a coagulation by the thermal destruction. But this is in a few seconds, this happens, all of that, but just means as longer you give energy logically, as more effect you have. It is like a microwave. If you put a bowl of rice inside the microwave for 10 seconds, it's not very warm or even nothing happened. If you put it for 4 minutes, it might burn. So here's the same. As longer you give energy, as more effect you will have. And we will not need so hard the last step with necrosis and thermocoagulation with the really cold reaction, because we see even on the denaturation of the proteins already some result. What you see here now is a thermocoagulation showed in a phantom gel. We just have the probe inside, and we now step by step, under giving energy, we're going back with the probe. And it's not so good to see now on this, but we will do now soon a cut of this phantom gel, and you will see then this line of thermal destruction, which is really, now you can see it better, which is very controllable because the energy is only in a radius active about 3 to 5 millimeters. So when you use that, you can have a very controlled energy source, and you will not have damages of other organs like the sphincter. Here you can see now this super controlled, very clear line of destruction. Means if you use that and you have a bigger pile, you will not be ready with one line. So you need to reach different parts of the hemorrhoid, which I will show you later. Next. These are now the equipment, what you need. It's the generators, plural, because there are now 2 on the market. The left one is the older model, still working very fine. It's but only for 2 possibilities. You can treat hemorrhoids and anal fistulas, which is a complete other topic, but there exists also a probe for that, which is called Fistura, where you can do radiofrequency ablation from the anal canal of fistulas. But other topic. The right generator, the newer one, as you see, there are more skills. You can use it for hemorrhoids, for fistulas as well, but then also for the veins, for the collateral perforating veins, for the venous veins, and for the small spider veins, for this teleangiectasia. You can also use it. We don't use that for that, but I know of several surgeons, vessel surgeons, who are using it already. Yeah. So the probe is almost 15 centimeter long metal probe, which is good because it's resistant, it's steel, so not easy to bow on one hand. On the other hand, you can target it very well to your position where you want to insert the tip. And the tip itself is only 1 centimeter active. We have isolation ring, which is a plastic ring. You see it here in the magnification. And from there on, the probe is not isolated, so the energy will flow in the last centimeter. So the rest of the probe is covered, so safe. And as I said, the radius as it worked is 3 to 5 millimeters, so very controllable. Next. The company here in Germany or in Europe from FCare, they provide the consumables as well in a package, which is very nice for people who maybe doesn't have everything prepared anyway in their office, because this is an office procedure. We do it really as an office procedure. Means patient comes in, get the treatment, 20 minutes later he goes out. I am able to do 3 procedures in 1 hour if I want to, because I don't have any OR rules about hygienic or anything. It's an office procedure, so we can do that very fast. We don't need a drape. It's inside the package, but I never use it because in my opinion, you are not able to create a sterile area at the anus. Doesn't matter whatever you will do, it will never be sterile. So we don't use it, but I do a little disinfection, and later then you have in this consumable package the anoscope. This red ribbon, what you can remove is that this anoscope is a self-lightening anoscope, so you don't need even electric light source. You can do it without. The probe itself is included, a forceps, a lubricant, and this syringe, the needle, which is very important because I love it. It's long enough and still stable to put later the local anesthesia, because this is the maybe most tricky step in the whole procedure. And for that, you need a long needle, which is stable enough that it doesn't bow too hard. So this one is very nice for that. Next. Yeah, I will tell you now something about procedure, and we do this also in some steps. We start with the instrumentarium, and this is what I just said already, what is in the package provided. So you have the syringe, local anesthesia we take. It's nothing fancy. We use usually only lidocaine 1%. We have this special long G20 needle from the Brown company. We have the anoscope. Interesting there is, I told already that it's a self-lightening, but it is in the end open, so it's not a completely circle. So when you remove the obturator, you have a gap at the end of the anoscope. So the targeted hemorrhage will really drop inside this, like a window or gap in the endoscope, and you will have it perfectly in front of you to do the treatment. Then we need a bowl of cooled saline. If you take here sterile saline, or you have good water quality and can just take cold water from the tap. Also possible, some colleagues I know take even ice, really ice water, which is not really necessary, especially when you do it like we do in local anesthesia. It's not very comfortable for the patient to use ice. So we just take cold water. And you have, again, this forceps and some gauze. Yeah, the positions what we use usually, we do the lithotomy position, lift our legs a little bit more up than it's shown here, that we can reach the anal area properly. The other positions might be still in use. I just can tell you that the left lateral position, it's a bit difficult for the procedure because all the time you need one hand to lift the right butt. And the knee elbow position, well, we don't do it at all anymore in Germany because it's not very comfortable for the patient. Now we try to show you in steps how the procedure works, and always try to make the animation on the left side, the real picture on the right side, and compare that, which is not easy all the time. But you can see now in the first step, we insert the endoscope. We use usually the 2.3 centimeter endoscope. And there is another one, 1.8 centimeters. Might be interesting for the Asian patients because some of them, you know it better than anyone, are a bit more tight. I mean, in Europe, we don't have that problem so hard. So I use usually the 2.3 to have a good access. But with 1.8, it's possible as well, just a bit more tiny. So you see now we put it inside, remove the obturator, and in the left picture, you can see how the hemorrhage drops and falls into this gap. Next step is now this, what I told you, maybe the most important step, because we have now to put the local anesthesia, and this is a very special location because we have to place it directly below the hemorrhage area, but not in the muscle area. So we want to be between the hemorrhage, the supramucosa, and the muscle area. As you see on this left picture, it's not so good to see this purple or violet small pillow in the hemorrhage, which is lifting the whole area a little bit, but we don't create a balloon. We don't want to blow up the hemorrhage. We want to put it under to protect the deeper layers like muscle, and to have still a local anesthesia. So this is maybe the most important step. We use the needle 30-degree. I go inside to the under the hemorrhage, above the dental line, and we give 3 to 6 milliliter of this lidocaine 1%, and then we have the lifting effect. On the right side, you see the picture. As you can imagine, for that pictures now, we had to use not the biggest hemorrhages which we could find. You might say there is almost nothing to see on this right picture, but to show you the perfect locations, it was easier to take pictures where you can see at least something. And if there would be now a fat pile in 3rd-degree, you would not see so well where the needle is located. Next. So now the second step with anesthesia is done. And now it's important that you don't lose time. The whole probe and cables and everything, connection and working test should already happen, because after the local, you want to take immediately the probe and insert in the same position where you insert before the needle for the local. So there is no time for the tissue to develop bleeding, to develop enema, to develop a hematome. You have just take the needle out from the local, put in the probe, and start immediately with the process. For that, you have to lift up the whole hemorrhage. We start in the middle of the pile. We go forward like 1.5 centimeters until the ring is completely covered by tissue. We lift the whole area into the rectal center, because this is the second step of protecting deeper layers beside the local. We will now lift the whole area. And you see on the right picture, it builds like a little tent around the probe, because this is the show that you lift it. And I use usually the edge of the endoscope to lift the whole area up. This is what we are doing right now on the right picture. And then you can start the procedure. In the first step, at the first position, because there we think the feeding artery, you should start and keep it like for 10 seconds to treat the feeding vessel. And then you can start like a fan reaching other areas. I would recommend go forward, go backward till you're almost out. And then you can go to the left, again forward, go backward, and the same on the right side. So they reach all areas. A tip is not to give energy if you go forward, because if you go forward and you give energy, you create already a coagulation around your probe, and you will push this coagulated area up in front of your needle in deeper layers. So I recommend give the energy only when you go backwards out of the hemorrhoid, and when you go forward, just don't use energy. This is the reason why you sometimes why we sometimes have the foot switch activated and sometimes not. And this is the reason why we have a wave of energy. So if you used to have, for example, laser, you will be shocked about the energy numbers here from 1000 up to 2500 joule. Because in the laser, you are using, I think, between 200 and maybe maximum 500, but much less. Reason is laser works immediately with the full energy power and during the whole time. It starts immediately with full power and it keeps it all the time. Here we have friction in the molecules. So the energy has to pause a reaction which needs a little time, which causes a curve going up already using joule. Means you have more joule in the end of your digital screen showed as used as you really used in the patient. This is the reason why you have 1000 joule maybe for second degree, 1200 to 1500 for the third degree, and higher even up to 2500. But this I will explain later. But for this is the reason why you can even spread the energy like that. And sometimes if you have a very big pile, you can even do a second insertion, because sometimes you cannot reach everything with that one. Next. So what you can do, and what we did in the beginning, after this, you can also treat the surface. If you think that this hemorrhoid was very thick and the surface was not completely treated, means you didn't see a shrinking effect, you didn't see so well that the color of the tissue changed, then you can do also surface spots to reach the superficial vessels. This we did in the beginning very often. Meanwhile, we recognized that we think that it risk a little bit, or we raise the risk for a local bleeding more. So we now, if it's not really necessary, skip it. Where we do it is when we see an additional rectal mucosal prolapse. But what you can do very nicely is do on the mucosa above the hemorrhoid, create some stripes by the probe, like a destruction stripes on the mucosa, which will cause a shrinking effect. So you can treat in the same time also the mucosal prolapse, which is very nice. And you have a retraction which happens immediately. So prolapse usually is gone after next day, after the treatment. Next. In the end, you just cool down the whole area with cold water, saline, whatever. Just cool it down, because it's not, when you do it a local, it's not so comfortable for the patient when you just take out the endoscope and he will have a contact of the treated area with non-treated area, because then it might be hot. So just cool it down, then you can remove the endoscope and everybody is fine. Yeah. So I now collected some pictures for you. As you can see now, the treatment in several pictures. We start on the picture left in the beginning. Well, go back. So in the beginning, you see the picture, a skin tag around. You can see it's just almost not, but you can see the edge of this white net trouser. So it's in my office. We just made a hole in this net trouser. There's no sterile drapes, as I said. We insert the endoscope. The third picture, you see now a bigger pile. The dental line is marked by this small anal polyp, which you also can see. And we introduced, we inserted the needle for the local directly above. We administered local. We didn't have a balloon effect. We put immediately the probe inside and started the procedure. So now you have to look very carefully because you can see on the next picture that there is a little changing of the color. It becomes a bit more purple-white than before. It's easier to see, I admit, when you do it and you have it in front of your face, the whole area. But here you have to believe me now. When we took it out, or when I took it out, I coagulated the insertion point. And then in the end, in this case, I did some local spots. So you see in the almost last picture, you see now the end result. And the last picture, interesting now, shows something which happened sometime. Because the skin tag on the first picture, which is not touched, not removed, only because of the shrinking effect of this procedure, the skin tag shrank inside, like disappeared, even if I didn't touch it. So this is the reason why I always tell the patient when they ask, can you remove the skin tag in the same procedure? I always tell them, wait, because you will lose the local and the effect that it's almost painless when we do it in radiofrequency ablation, the hemorrhage treatment, because then you have a wound, which you will feel. And maybe it will disappear during the treatment and you will not have any skin tag at all. So let's do first the treatment of the hemorrhages. If you still have an annoying skin tag, which you want to get removed, we can do it later. But this is what I recommend. Next step. So what do we do in postoperative recommendations? In the trial, which we had years ago, we didn't do any recommendations. We just told them, take painkillers only if you really need them. Now, because we are out of the trial and we want to have comfortable patients, that they are fine, we tell them take 2 to 3 days, 2 to 3 times a day, ibuprofen, like 400 milligrams. It's very common in Germany to use that. If you want, you can use a lidocaine ointment for local treatment. And for people who have problems with constipation, we recommend also a stool softener. This is what we do now. Next. Very important to understand where the complications can happen is to know the healing process from this whole procedure. And we have in the beginning only the coagulation, and then the next 7 days, not so many things happen. It's just the necrosis time. But from still day 7 to 14, we have that this necrosed tissue will exfoliate and the wound is formed. So there might be a bit bleeding. Statistically, 1 to 2% will have a bleeding which they recognize. It can be a bleeding which really is to see in the toilet or just at the paper when they clean. You know, in Germany or in Europe, we are not used, sadly, cleaning after motion with water. The people here are used to it, which is for you not to understand, I know, but in Germany and Europe, we are used to clean with paper, and usually dry paper, which is completely senseless. But we do it. It's just a habit. And this is the problem why they sometimes have bleeding at the paper or they see it in the toilet. And then after 14 to 21 days, it's usually only the fibrosis, so nothing happens. But so you have to be careful and tell the patient, be aware, between day 7 and 14, it can bleed. If it happens, just go away from the toilet. Don't watch yourself bleeding out. And then I tell them, just take a seat on a wooden chair or something hard, not on the sofa, to have a pressure against the anal area. And then usually it stops itself. We don't have, or I didn't have long time a severe bleeding which needed any treatment. Next. We have some contraindications, indications which are not clear if they all really like that. We start especially with the first one, which is not completely clear, because if you have, we have to, or the company have to write it. It's a contraindication, but I did it already with people with a pacemaker. When they have a new one, the pacemaker is able to recognize that the electric source is not from the body, it is an external electric source, so nothing will happen. This is what explained to me the cardiologists, and we never had a problem. But you have to decide this by your own from case to case. Pregnancy for sure is a contraindication because of a pregnant woman, you can even have problems with indicating some convulsive reactions or some muscle retractions. This you don't want to. Young people, well, this is not a contraindication only for the treatment with Rafaelo. It's at all, because I think an operated treatment like that you should never do in a young person, because as we all know, often it is a self-limiting disease in young people, but you can do also sclerotherapy or whatever. So when you have a problem with local anesthetic, for sure, then you can do it like that, but still you can do it in general anesthetic, so that's possible. If you have any infective or pathologics like fissures or other infections, you should not do. What we usually do, if we see a slightly proctitis caused by the hemorrhoids, we do a pre-op therapy with some steroidal suppositorium 10 days before the procedure so that they are calmed down in this area before we treat. The staple previous longo is still written in contraindications, which I honestly don't care about because I do regularly. I have patients which has 5, 6, 7 years ago from somebody somewhere, a stapler hemorrhoidectomy with still inside some of the metal pieces of the suture, but I do the treatment and they don't have any problems. We were scared that they are too hot maybe or something, but I never saw that. And the last is most important, patients with bleeding disorders. This means also all patients which take oral anticoagulations, which are stronger than ASS, like acetylsalicylate or aspirin. This is okay, but more I would not recommend. Next. So some examples just here for you when you see now before and during, immediately and after. We have here on the 11 o'clock position, nice pile. Immediately after you have this shrinking effect. And after 6 months, there was only left this white small scar, nothing else. So this was the result. Next. I get always the question if it works for hemorrhoid grade 4, which is for me sometimes surprising because in my experience, grade 4 goes almost always together with the big skin tag, usually. So there is often the reason for the people that they want to get removed it because of the big skin tag and the fixed hemorrhoidal tissue. So I think it's not often a really good indication to do it by Rafaelo. But if you have, like in this case, this small pile, which was indeed 4th degree because I couldn't push it back, it always that was there fixed. I did there a Rafaelo, which was not so comfortable for the patient because as you see, the dental line, it's even prolapsed to almost outside. So there was very difficult to avoid the dental line with the injection and with the probe. So this person had a bit pain during the procedure. But as you see, it was a very good effect. After 1 week, completely disappeared. And inside the necrotic tissue, also after 1 week, showed also how it works inside. So even if you don't see so much effect, believe me, there is effect in the tissue. Next. Yeah. So now I'll let you just brief a little bit and because you heard now a lot about the technique and everything, but we wanted for sure have some numbers to show that it's not only in our brain that it works nice. No, we wanted to have really proof. So we started a long time ago a trial, and in this trial we compared it to other therapies. As you might know, in Germany, 3rd-degree hemorrhoids, and this was the main target now of this trial. We usually treat them by operative therapy. Very classic here is the Milligan-Morgan, or just the excision, or it's not anymore, is the stapler hemorrhoidopexy. It's now less and less used, but before it was very common. Now we do mostly in 3rd degree or in 4th degree Milligan-Morgan. So, but there, as you know, it's a painful procedure, disability time after this, patient feels ill, they're not very comfortable, and they have restrictions in daily life. And here now we tried with another center together to evaluate if this is in using 3rd degree for this radiofrequency ablation, if we will have better results in complication, in postoperative pain, and a restriction in daily life. Next. So for this, you see how old the trial is because we started already a long time ago. but we have still the same results. And we, meanwhile, did even a follow-up of this and checked it also after 24 months, and the results are always same. So we checked between 2 years because we wanted to choose real people with real third-degree pile, means it was a prolapse, and they report they had to push it back by their finger. So really third degree. We choose around 100 people. It was mostly men. The reason is because in this trial time, we were 2 men in my practice, and in the other center, also 2 men. And as you know, usually women try sometime to go to an examinator or a proctologist, a female one. We couldn't offer this, and this was the reason why we have only 11 females, but usually it's different. In the follow-up, we checked after 1 week procedure, after 4 weeks, after 6 and 12 months, and if it was possible, after 24 months. And we asked for the use of painkillers. We asked for the disability in any way or complications. And to have a survey, we used the projectological symptom score, which is very easy, just 1 or 0 to 10. And from that, with the different symptoms, we could make then a really score. A symptom was scratch, itching, bleeding, and this stuff. So these are the results of the demography. We see now around 50 years old mean age. We have, as I explained, more male. BMI, well, this is European. Yeah, if you do this trial in America, it would look quite different. If you do it in Asia, I think also because as I saw a lot of people in Asia, in Malaysia, in Thailand, and wherever I've been, so slim. This is what we always think when we go to these Asian countries, that we always think they're all in shape, what I see on the street. Maybe you have different opinions. And half of these people had previous treatments, like sclerotherapy or ligation surgery, or even also radiofrequency ablation, because we sometimes, if it was circular, we took maximum 2 piles we treated in 1 session. So when we did it in 2 steps, we counted them also as pre-treated logically. Average joule was 3,000, and we managed in 85%, we managed it in local, and 15 people, we did it in sedation. In our practice, we have regularly endoscopy, colonoscopy as well, and gastroscopy, which I perform. So we are all used to propofol and sedation, and we could offer this. Next. Complications at all. I mean, we really put now everything inside, which could be a complication, but mild bleeding, well, every time when you treat something, it can be a little bit blood, but we counted it. Interesting is sometimes, and this happens really, they had subfibral temperature. It's called to this resorption of the necrotic tissue, can happen next day or even up to 3 days, up to 38 grad Celsius. It's possible, but that's all. You don't need to do anything. Well, pain and diarrhea, this is just because of the activation of this area that you have more the feeling you have to go to motion. Anal thrombosis we had 3 times and increased urination. But the major complication is more interesting because in 4 people we had a bleeding. Sounds more dangerous than it is because 2 of these people, they just called us and it stopped itself. And 2 of them had problems with the severe pain. And we had to check them again. And these 2 people were the same who had also the necrotic ulcer. Was very early in our trial. And meanwhile, we think in that time that we just went too deep in the tissue with our probe. We hadn't have this ever after we had more experience. Next. Now we have a look at the score now. This is now this score about the pain. As you all know, there's we have usually this score also here. 10 is terrible pain and 0 nothing. And what was for me almost shocking for myself after this results, that 30% of these people had 0 pain, nothing, and they didn't take any painkillers, which I'll show you soon. So this was really crazy because I never ever had a hemorrhoidal operation like Milligan-Morgan or something like this. And the patient later told me he doesn't have pain. This was for me impossible. I never thought that it's possible to treat in this area pain less, but it is possible, and I was surprised myself. So 1/3 didn't have pain at all. And you see even in the 1 and second score here, 1 to 3, the most of them, the majority of people was still 1 to 3 in the pain score. And for sure, like always, there are people with maximum pain. But by the way, these 2 people with pain score 10 are the same who had this ulcer, which I just showed you just now. So it's the same group. But altogether, majority was without a lot of pain. What answers this question as well is when you ask people how many or how strong painkillers did you take? And this is also really an incredible outcome. And I can only assure you not often enough how honest we have been with taking our data, because we wanted to know as well, is this real? And we saw 65% of our patients didn't use any painkillers. This might be a little specialty in Germany because people here, I have to admit, they usually don't like so much painkillers, and a lot of them tell you, oh, well, but not so hard, I avoided it. Other countries, as I know, they would take painkillers much faster, but this was a reality now in our trial. And only a small group of 16% took longer than 4 days to 7 days painkiller. So it means also here the big majority took nothing or only 3 days painkillers. Next. When you look now to the score, which was this 4 different qualities of symptoms. I told you itching, pain, bleeding, wetness, and the total. We saw before the procedure, we saw here a total which came up to over 8. And some of them, for example, the wetness and bleeding also was even all 2 and 3, so it was not so low. And after the procedure, after a longer time, even 3, 6, 12, 24 months, we didn't have a so hard rising of the total symptoms. And if you would now go, what I always say, and interview people here on the street today, just go out here in Cologne, where I'm in, Cologne, Germany, go to our shopping street and ask 100 people, do you have sometimes itching, pain, bleeding? And they are not aware of having a hemorrhoidal disease. If you just ask them, you will have exactly the same results. Because everybody has sometimes of these people also a bit itching, maybe once in a week or in a year, maybe pain. So if you have a score, you have always the same as we had now after treatment. So I think it is quite normal and a very good result. Next. Now everybody asks what you can say in compare to already existing therapies. Is it better? Is it worse? How you can compare? First of all, I have to say it's extremely difficult to say how well worked hemorrhoid treatment. Why? Because we are thinking about recurrency rates. If you have a broken arm and it's rebroken, you can say, yes, this arm is at the same position broken, it's a recurrency. Or you have a sickness, a cancer, I don't know, liver metastasis, and comes again. Yes, it's a recurrency. Here, we treat very local areas, for example, 3 and 7 o'clock. For example, 11 o'clock position, there was nothing to treat. And then a half year later, this patient comes again and tells you, I have again itching or bleeding. And you check inside and you see 11 o'clock is the reason. 3 and 7, which we treated, there's nothing. So would you call it a recurrency or would you call it a new entity? Is it a new hemorrhoid sickness? And this is in all trials not clear. None of the people with all these trials, which I show you here now, had here a clear definition what means recurrency, because the symptoms are this what they are calling. This is a difficulty. Here we have now, so meaning now recurrency means there is a recurrence, there is a symptom again, wherever it is caused. So the rubber band ligation, which is shown here, compared to the HAL-RA in the Hubble study, You see after 12 months recurrence, they have in rubber band 50%, 30% in the HAL-RA, which is high. And the surgical excision, this is the so-called ethos study, and the stapler hemorrhoidectomy, they are also with high recurrency rates, 14 to 32%. Now, our own data, they look nice in compare because we had 17% recurrence. But I can tell you, I had only 3 cases which had really, in that time, on the same position, again, a treatment of a hemorrhage. Usually, it was another position, like I just explained, 11 o'clock, which we didn't treat before, and now it was like that. And after 2 years, we have still 23% only, which is very, I think, compared to the other procedures, very nice. Next. So I come to the end step by step. The conclusion, we have radiofrequency ablation, third-degree hemorrhage, which we are used now to treat here in Cologne with a Rafaelo. We see that it's quick. I showed you before these pictures with this guy with the skin tag. The whole procedure, what you saw on these pictures, was less than 1 minute. So it's quick, it's low in pain, it's safe, and it's a very effective treatment, because what we always want is that the patient has less or no symptoms with a very safe procedure. And this is, I think, what we found here. It's really a tailored approach. You can do what the patient needs and don't overtreat. Moreover, we have here the situation that it's outpatient, so we don't have any restrictions, like, for example, what we had during COVID. You see now on the next that you need an OR. We could go on through the whole crisis by COVID with our treatment because we didn't have any restrictions, because it was an office procedure. And I worked before, for example, 2 years also as a consultant in Dubai, and Dubai was completely shut down. There was no possibility anymore to do radiofrequency ablation because there you had to do it in the OR, and OR was only reserved for emergency surgery. So there was 2 years, no option and possibility to do this treatment. So thank you for your attention. And now I think I filled your brain with a lot of information. And maybe, I hope I didn't talk too fast, because I love to talk fast. I'm half Italian. This might be the reason. So I think now it's time for Q&A, right?
Yes, thank you, Dr. Tivaldi, for your generous sharing, and thank the other doctors who were giving your full attention. Now you are free to ask questions. Dr. Vivaldi, can you see there is a question from the chat box?
I try to, I try just to open, yeah.
So
I think I have to read this because not everybody can see it now. So there was a question from somebody from Indonesia. His questions, first, his question is, can radiofrequency treatment be performed for grade 4 hemorrhage? I think I just answered this also the question, what I just said. Yes, we did it in the small ones. But again, I say that the question is often coming, but I think because it's very often combined with a big skin tag, I think the better treatment would be a resection of the grade 4 with the skin tag together. But in small 4th degree, yes, you can use it. Second question here was, what are the advantages and disadvantages of radiofrequency compared to laser for hemorrhageal treatment? It's also easy to answer because the temperature in the radiofrequency probe comes maximum up to 100 degrees, maybe 90. So you have a destruction in a very controlled around 3 to 5 millimeter area. The laser comes up to 350 degrees. It's extremely hot. So you will be not able to do that in a local anesthetic setting. And for us, it was one of the most important reasons, because we wanted to have something for outpatient procedure. Next difference between laser and radiofrequency is the probe. In laser, you have a soft probe which you cannot lift. And in the older described techniques, today they change it a little bit. You had to approach the hemorrhoid by doing a cut in the anoderm outside and tunnel to the hemorrhoid, which is, in my opinion, not a good technique because you destroy completely intact tissue. But this was before. And you have a soft probe, which you cannot lift. So the danger to destroy around muscle or other layers much higher. And as you know, 10 to 15% risk in laser to create a fistula, which is zero in radiofrequency ablation. I think these two are the main advantages of the radiofrequency: much less local damage, less heat, and no destruction of intact tissue outside. And you can do it local because of less heat.
Can you treat external
Dr.
hemorrhage?
Harry?
So there comes another question now. I'm just reporting now further on. It goes in the same direction, also from Indonesia. Question if you can use radiofrequency treatment in external hemorrhoids. Well, this is the problem now because external hemorrhoids, we have to make a definition again. Germany and Europe, they don't exist the word external hemorrhage. We don't have that. Because the definition in Germany of hemorrhage is a vessel between arteries and veins. External hemorrhoids, I think you mean the perianal veins, are not in that definition because they are only veins, they don't have arteries. So we don't call them here hemorrhoids. We call them skin tag or perianal veins. To answer that question, it's under the dental line, so it's very painful with radiofrequency. I would not recommend to treat that in local outside. You can do it for sure. You can do everything if you want, but it is created for third degree to second degree, even first degree if you want, but for internal treatment and not outside because there's the skin, which is very sensitive. So, oh, wow, now comes a long question now. Okay, I just go on now like that. Yeah, I just read them. And I mean, if anyone wants to interrupt, Michael or wherever you can do, but I will just
No.
go.
It's just I will read the questions for you because
Yeah,
what are
I
the
think
main factors that determine the success rate of RFA in hemorrhoids?
The first question was the main factors that determine the success is you have to choose wisely. As with all procedures, doesn't matter what you have, what you do, you have to think about which patient fits to which procedure. Not one procedure fits everything. And even if you have now a new hammer, not suddenly everything looks like a nail, but it's not what you should do. It means think about if it's third degree, what is the main problem? Can we use it local? This is the success rate. If you take patients which are wrong indicated, for example, they don't have a big hemorrhage problem, they have a real rectal prolapse completely. This is something different. So just be sure you have the right indication. Then it works very well.
Okay, and how can you control the energy? So avoiding surrounding tissue damage.
Well, first of all, experience, because you know how much tool you can use. Second, we have these two steps to avoid deeper layered damages by the local and by lifting the whole probe, both things which we don't have in the laser. So you can avoid this, that damage deeper tissues. And you don't have a control. The machine will not tell you now it's too much. There is a signal after, I think, every 500 joule that you are secured that you don't need too much, just to let you see. But in the end, you are the surgeon. You have to decide. And we do usually then when we see that this becomes pale or shrinking, then we know there's an effect. I don't wait till there's cold. Then it's too much. We don't need that effect.
Yeah. And also there is a difference because with radio frequency, if you overshoot with 100 or 200 joules, it's not the end of the world. With a laser, it makes a big difference if you overshoot with 200 joules. So I think there is less risk of tissue damage is more controlled with RFA than with laser. You'll be
Next question is about the complications and treatment. Well, I just showed you in my trial what the complications are, what we saw. And the most important thing is what we really have to tell them before is the possibility of bleeding between 7 and 14th day. And usually it's self-limiting. So I just tell them, as I said, sit on a wooden chair or whatever, it will stop. What we sometimes provide the patient when they live more far away and not from our area, because we see them usually after 1 and after 4 weeks. But when they are far away and they cannot come, I give them sometimes a tamponade. It's like a hemostypticum, we say for this, like a sponge. In case of bleeding, they can just push it themselves in the anal canal. It will stay there for 2 hours. It usually stops all bleedings. If they have this and they are far away, I provide it and give it them.
Okay. Yeah, that's a similar question, how to determine the energy level. So of the treatment duration for each hemorrhoid. Well, that's something we answered. So it's always at the same energy level. It's at a 25 watt or 100%. That's always the same. It's just a duration. So less in grade 2. So 1,000 joules. So we give like these guidelines to say like 1,000 joules in grade 2 could be 900, could be 1,100. Grade 3, like Dr. Vialdi explained, 1,200 to 1,500, and grade 4 up to 2,500. Those are the ranges, the guidelines that we give. For sure, you're not going to use like 2,500 or 3,000 joules in grade 2. That's overcooking everything. So you have to look for the reaction as well of the tissue. And if there's not, you have to rely on the generator.
What we are not allowed to forget is that we do it in the outpatient procedure in local. So there is one person who will tell you all the time it's too hot and too much. This is the patient himself. If you have it in local, you will not be able to damage too much, because if it will have too much energy that it can damage something, patient will already tell you now it's too hot. So this is exactly the perfect situation with this feedback, why I think that the results are also so good, because you cannot destroy nerve endings without recognizing from the patient. So he will tell you now it's too hot. You can always change the area. You can cool down the area. All advantages which you don't have when he's in general anesthesia.
Okay, how does the RFA technology helps maintain natural functions?
Okay. Help maintain the natural function of the hemorrhoidal cushions are, as we all know, it's like the ring in the shower always said, to make a fine tuning, that to close it, that
Mẹ
there's
ơi,
no witness.
à,
This we know all of us. So, but how does it
Linh
maintain? How does it maintain the natural function? Means we just put them back in the position where they belong, because the hemorrhoids, as we all know, they usually above the anal canal, so above the dental line. And the hemorrhoid is nothing else than this vessel cushion, which is not in the correct position anymore. It's slapped down and it's like sliding outside step by step till it has a prolapse. And because of this shrinking effect and the reduction of the whole vessel size, we can reach that it goes back to the normal position. And it is often that I see afterwards that it's not completely disappeared. It's not destroyed always, not always a scar. Sometimes, if it's a very thick pile, you reach a reduction of the size and you can just bring it back to the normal size. So there's still a vessel, still a hemorrhoid, but just smaller one, which is in the right size to get back the natural function. So there is a little implementation in this question if we have after this problems like they are not incontinent or have problem with wetness. We don't. It is really that we reach a natural, again, working cushion area.
Okay. There's a more technical question on the patient selection. So the current Gallagher system is blind to the volumetric size and the exact number of treated piles, which can significantly affect the tissue response to radiofrequency ablation. Did your research look into the correlation between the clinical outcomes and the specific characteristics of the piles, such as signal versus multiple or fibrotic versus vascular? And furthermore, would your protocol for tailoring the energy delivery in joules based on the volume of the tissue?
Yeah, well, this includes several questions, but they are all very intelligent and smart. It's good questions. First of all, it is right. The Golliger system, which is almost, I think, more than 100 years old now, is just 1, 2, 3, 4. It says nothing about the size. I mean, the Golliger system is anyway a problem because everybody of us knows that there are sometimes hemorrhages. We would love to call them like it's a 2 plus or a 2B, or I don't know, because it comes out a little bit. It stays maybe for 1, 2 seconds, which is a prolapse, but it goes back itself without pushing my finger. But it's more than a second degree. So I think we all agree that there should be a better, anyway, definition of the size, but we don't have. So what we have here, as I already said, you have sometimes piles which goes from, I don't know, 7 o'clock to 11 o'clock in one big block pile. I use even 2 insertion points and treat them. How I know how much energy I need, because I told you I look at the tissue, I hear to the patient, and I see the reaction. And if I see that the tissue comes pale or change the color and the shrinking effect starts, then I know there is an effect, and then I can stop it. It's not necessary, as I said now several times, that you wait till you have a really black area. This is what we don't want, because then it's too much energy. Already happened something. Even when you start with less energy. Don't overdo it in the beginning, thinking you need to see a really hard reaction, because this can really make the whole procedure in the end not working, and then you might be very disappointed about a really good procedure and thinking it's not worth it to start, but it's really good. Specific characteristic of the pile, as I said, it's very difficult. What we addressed was the problem with single and multiple, because in our trial we decided, and still I do it like that, if there are more than 2 real 30-degree piles, mean 3 or 4, I do the procedure in 2 steps. I start on one side to hemorrhages, and then after 4 to 6 weeks, I do the second side. This is what is very controlled, and with that, you will have not headache.
Okay. Can RFA be safely combined with other minimal invasive techniques for the treatment of complex?
Yes. I mean, you can combine everything what you want to combine. I don't think it's now so sensible to combine it with laser, but you can, when you minimal invasive treatments like sclerotic therapy, for example, if you think so, or larval bud ligation, for sure you can treat, for example, now 7, 11 o'clock position, 30-degree hemorrhoids, you treat by Rafaelo, and the 3rd-degree or the 2nd or 1st degree in 3 o'clock position in the same time you do sclerotic therapy. True, it's possible. You can always combine that, or you can combine a HAL-RA intraoperatively, maybe with radiofrequency ablation. Everything is possible. I didn't need that till now, but you can do it.
So if you have a severe bleeding after 7 days, what can you do?
Well, we had twice the situation that they really had the dropping bleeding, which didn't stop itself, even after sitting on the wooden chair. So what we did, we always tell them very often, please don't go to just a hospital around you, come to us. They all have a 24-hour emergency number from our practice and they can call. Because when they go to any hospital, still 80% of the hospitals never heard of Rafaelo, which is crazy because on every German Congress I'm telling something about it, but it is like that because still it is not a typical treatment here, sadly, but it is true. So when they go to another hospital, they will be catched and immediately in the OR when they tell you they have bleeding, which is not necessary because when they are in our practice, I check inside. If I see the bleeding source, sometimes it's really one small arterial branch, which is a little bit bleeding, you can just make, even with the same anoscope what we use for operation, you can just make one suture with a Vicryl 30 on this position, and it's done, usually. So it's not a very difficult procedure to stop the bleeding. If we have seldomly during the procedure of bleeding, we do the same. I always have prepared a Vicryl 30 besides, just in case that there is a bleeding and I need one stitch.
Okay. And how do you assess? How do you do your assessment of patients for RFA?
Yeah. First of all, we have to check if there's contraindications for sure. For me, it is always because we have. Some might think we do know everything with Rafaelo. No, we don't. We have a large amount of patients which we just treat still by sclerotic therapy, rubber band ligation, because they are not so big, the piles that I think we need now, the Rafaelo. When do I Rafaelo? Usually when the person sits in front of me first time in office hours and it tells me he has a regular, during the motion, prolapse and he has to push it back. Because then I know sclerotic therapy, rubber band ligation will not work very well. And for these people, it's perfect, especially when there are people who had several treatments already by sclerotic rubber band didn't work. And we can offer that. Very, very grateful are people with bleeding, because against bleeding and prolapse, it works very well almost immediately. Problem, like always, are the people with itching, because itching has millions of reasons. And it's, I think, the worst and the most difficult symptom to treat. But for the bleeding and the prolapse people, they are perfect for this treatment.
Okay. How can RFA treatment be optimized for patients with combined internal and external hemorrhoids?
Well, here we are again the problem with the definitions of the external hemorrhoids. Would love to know exactly what he means, or the colleague means with the external hemorrhoids, because I told you just now, when they have the skin tags outside the perianal veins, because of the treatment of the inside hemorrhoids, the real ones, we have a retraction and a shrinking effect. And usually, because the blood flow at all is then more natural and better, the perianal vein plexus, which might appear very thick, flattens usually itself after the treatment. So I don't do a specific treatment of the external hemorrhoids.
Okay. Oh, I think we had all the questions. There are no more questions.
Or doctors, do you have any more questions? You can unmute and then you can ask directly. We still have time today, and this is a very good opportunity to ask our experienced doctors.
Well, usually when nobody has to ask something means you explained very well.
Yeah, I think so.
Yes, there is more. There is a more question in the chat box.
How does RFA technology affect the pressure and the mechanical stress within hemorrhoidal tissue after treatment?
Well, because the radio frequency will reduce the size of the hemorrhoid, logically it will reduce also the pressure. But you mean when they have, for example, constipation or something like that, if we will have a problem. This is what I said after the treatment. If they have or they report regular constipation, I will always give them for like 2 weeks a stool softener. And in any way, all of them should do, as you know, a stool regulation. Well, we do here in Germany regularly the encapsulars. Now we prescribe the psyllium. So, as you know, Plantago ovata, the psyllium, which is very, very common for the stool regulation, and we give it here almost every patient.
Now
Okay.
another more question from the chat
This
box.
is interesting now. This is interesting because there is somebody
Laser.
who use the new laser diodes. They are less hot. This I didn't even knew myself. They must be very new. because it's 1.470 nanometer, create only 60 to 80 degree. Well, I believe you because you wrote it and you used it. I never saw such a probe, and I almost cannot imagine how the laser should control the heat. But everything is possible. I'm not an expert everywhere. So if he writes he has this probe, it might exist. But still, you have here the problem. I think that it's a soft probe and you cannot lift it. So it's not completely comparable still. And I would like to know if this person who wrote this ever try to do it then in local, because if it really comes only to 80 degree, it could be even something for local therapy, laser. No experience with that, cannot take anything about that, but thank you that you mentioned that there are new probes. I didn't know. 980, one last sentence to this, 980 nanometers is an older one, even if it's colder with 60 to 80 degree. The problem is here that the diameter of working in this nanometer size is usually up to 1.5 centimeters. So much more effect of the tissue. The 1470 nanometer is less working in the diameter. So this is much more controllable.
Yeah, but still it remains a fiber, and it's glass tip.
It is actually,
The problem with the laser is the glass tip as well, because this can break. We had several cases reported from India where they told us that the glass tip of the laser probe broke and they had to do a terrible vasting operation because you cannot see an X-ray, the glass tip. So they had to find somehow this broken glass tip. Anyway, I say again, my experience are with the new probes less. I stopped laser when I started radio frequency ablation. So I followed the development, but I don't do it anymore since 10 years. So.
Okay.
Yes, in the Asian countries, the 1470 fiber is quite common.
Yeah, which is the modern one. It's a good one. I mean, much better. I mean, they started, I think, with 380 nanometers. This was terrible, like 15 years ago. But this is a good one. I agree.
Okay. What are the most important technical recommendations for achieving optimal RFA treatment results?
Technical recommendation. Technical is most important to the local in the right position, because then you don't have pain during the treatment, you don't have damage of other areas morely. And the second step, most important, technical, lift up the whole area during the procedure. These are really the two most important technical recommendations to have an optimal result. But I think still to choose the right patient also. I mean, what you want in the end. I always say we will never create a new anus. The patient will never look like he's just born. We want a patient without symptoms who is happy. And this we can reach with this targeted procedure. Because a stapler, for example, you cut everything in one step and the patient has to take the results however it is. Here you have a tailored approach and you can do 1.2 positions, 3 positions. You can choose and you have to do that and choose right. So I think with these steps, you can reach maximum optimal treatment result.
Yeah, which anesthesia method do you use with RFA? That's something we explained, but you can explain again if you want.
It's only local, and we use 3 to 6 milliliter lidocaine, 1% as a local for every position where we do the procedure.
Okay, that was the last question. So I think we can finish now.
So no more questions, especially the doctors who have already used our Rafaelo system. If no, we're gonna close this webinar, and afterwards the materials, the useful materials can be shared to you. Okay, then good night for the Asian doctors. Thank you very much for your time. And now it's Friday. Have a nice weekend. And
Thank you.
Michael, Dr. Vivaldi, have a nice weekend.
Thank you. Thank you.
Thank you. Thank you very much for your
Thanks for
time.
this
Thank you.
opportunity. And I was very flashed about the people who took part, so many people, and very good. I wish you all a nice weekend and thank you for your attention.
Thank you. Thank
Thank
you.
you. Have a nice weekend.
Bye-bye. Bye-bye.